Hi, my name is Reid Pullen and I'm a board-certified endodontist practicing in Southern California. I have been practicing for over 10 years as a general dentist and as an endodontist. In addition, I have been lecturing and teaching throughout North America for a number of years. Whenever I lecture, I often get asked about the best ways to perform access on teeth. We all know that the access sets the tone for all of the following steps in root canal therapy. Over the course of the next hour or so, we are going to take a deep dive into some of the nuances associated with performing excellent anterior access. I've got tips and tricks on the whole process. We will talk about the tools you should be using. I'll give you some pointers on how to get profound anesthesia, and we will even take a few moments to talk about rubber dam placement. My goal for you after watching this webinar is to be comfortable and confident in your next anterior access, which will contribute to your overall root canal success. So let's get started. Here's our outline for this course. I'm going to discuss canal classification and the tooth morphology. I want to talk about some access tips and some of the errors that you want to avoid when you're accessing anterior teeth. I'm going to talk about the access armamentarium, the different burrs that I recommend using. We'll also talk about access technique when you're performing your access in a maxillary anterior tooth, a mandibular anterior tooth, or if you're accessing through an anterior crown, whether it be a porcelain fused to metal or an all porcelain crown. Let's try to understand first the canal morphology so you feel confident when you access these canals that you can address the entire root canal. The first canal classification is type 1, and this is one canal leaving the pulp chamber and throughout the tooth exiting the apex. This is a single canal from pulp chamber to apex. This is type 1, and thankfully this is what you're going to see the majority of the time in the maxillary, central, lateral, and canines. Type 2 canal classification are two canals leaving the pulp chamber and then merging as one and having one apex. We call this a 2-1 classification. The type 3 classification is the 1-2-1. This is one canal that divides into two that subsequently reunites and then exits as one at the apex. This is what you're going to see in some cases on the lower mandibular incisors. Up to 40% of the time, there could be this type 3 classification in your mandibular incisors. Now, the type 4 classification is two separate canals from top to bottom. This is an easy one to remember. Just like type 1 is one canal from top to bottom, type 4 has two canals that leave the pulp chamber and two foramen. Type 5 is a more difficult tooth to treat. It's a 1-2 classification or a 1-2 formation. You have one canal that ends up splitting in the root into two canals and having two separate foramina. These are difficult teeth to treat. An even more difficult tooth to treat is the type 6 classification, or the 2-1-2. You have two canals leaving the pulp chamber, then merging somewhere in the root, and then splitting again and having two separate foramina. Very difficult tooth to treat. These are the cases where you're going to need active irrigation, such as the endoactivator or passive ultrasonic irrigation, or PIPs. Here you can see the pulp horns in the central incisor and the lateral incisor, and as you start from a younger patient to an older patient, you can see how this chamber starts to diminish or calcify. So if you're working on a younger patient and you're accessing a maxillary central incisor, you're going to expect to probably penetrate the pulp chamber within 10 or 15, 20 seconds on a normal case. But on the other end of the spectrum, if you're treating an 84-year-old lady, it may take you 5 to 10 minutes to access the pulp chamber. And we're going to talk about some of the tips to do that, so you can be successful on that. Let's talk about the different tooth morphology for the maxillary central incisor. First off, it's good to know that the average length for the maxillary central incisor is about 24 millimeters. Thankfully, it's got the type 1 canal classification, which is one canal from top to tip, top to bottom. When you look at it in the facial view, the proximal view or the mesial distal view, or the lingual view, what you can see is you can see some pretty simple anatomy. These are excellent cases for you to treat and to be successful at. All of these maxillary central, maxillary lateral, or the maxillary canines are really great teeth. They have simple anatomy, and you can have a very successful outcome. So I encourage you to attempt the root canal treatment on these teeth. One thing to know about the maxillary central incisor, a lot of times it can have larger lateral canals. So if you have a necrotic case, you have to be careful. You have to make sure there's enough soak time for the sodium hypochlorite to soak inside the canals and to kill all the microbes, and not only the main canal but any lateral canals. So that's where I think passive ultrasonic irrigation or sonic irrigation like the endoactivator or PIPs, any of that kind of stuff where you're activating the irrigant inside the canal will really help clean these systems. Here's a cross-section of a maxillary central incisor. You can see that it's not really extremely difficult anatomy. Let's watch a video here. This is a great shot. You don't get to see this kind of shot often. They're taking a number 2 round diamond, and they're taking small bites, being careful, being gentle, and they're taking their time. In this case, they're just going to go right to penetration phase and penetrate the pulp chamber. They penetrate in. Now they're doing a little bit of a enlargement of the access, and they're being very careful, very gentle as they're slowly just taking away small bits of tooth structure. They're going to now go to the refinement stage, and I like to use a diamond, a thin diamond in the refinement stage, and really you want to refine this lingual triangle to get your straight line access. Here's the long thin diamond, and they're kind of refining that lingual part right there, and that'll give you straight line access. The biggest thing I see is that lingual triangle. Here's the DG16 showing you the straight line access. Now let's talk about the maxillary lateral incisor. That's got an average length of about 23 millimeters, and thankfully again this is a type 1 canal classification. So 100% of the time you're getting one canal from the pulp chamber to the apex. Now the one thing you want to keep in mind on the maxillary lateral incisor is this distal deflection or this slight distal curve. So about 50% of the time there's a 5 millimeter distal deflection in the apical third. You can look at the facial view of the maxillary lateral incisor and you can see that there's really not the complex anatomy in this case. Pretty simple. Same with the proximal or mesial to distal view. And then in the lingual view, you can kind of see that distal deflection in that apical 5 millimeters. And again, you look at the cross-sectional view of the maxillary lateral incisor, there's not anything that's extremely difficult. So I encourage you guys, if you have these cases, to go ahead and treat these cases. You can be successful with these. So let's review the maxillary canine. The one thing you want to keep note here is the average length of this tooth is long. It's 28 millimeters. So you have to keep in mind that you have to have 31 millimeter hand files and rotary or reciprocation files in your office. So you definitely want to make sure that you're prepared before you treat any kind of long case, and these canines can be fairly long. Also, you have to think about filling, obturating these cases. A lot of times when you're dealing with long teeth, long canals, you sometimes have to use a smaller taper. So if you only have 06 gutta percha, it may not fit into this length because of the taper is too wide at the coronal aspect. So you have to start thinking about these things and be prepared ahead of time before you treat the maxillary canine. Also, the maxillary canine has a type 1 canal classification, which is wonderful. 100% of the time, you're going to get one canal from top to bottom. Again, I feel that you guys can treat these cases and be successful. Here's a facial view of the maxillary canine, and the anatomy here is fairly simple. Proximal view, you can see that facial to lingual. There's a little bit more pulp tissue in there. So you definitely have to do your clean out phase and shaping mechanically and chemically, your chemical debridement well. Here's your lingual view of your canine. And then you can see in the cross section, you can basically just see on the mid root, you see that facial lingual dimension is a little bit bigger. And here's a video similar to the maxillary central incisor, accessing the maxillary canine. Again, taking this number 2 diamond, being very careful, taking small bites, taking their time. You want to take your time. You want to penetrate your penetration phase. This is the slight, gentle enlargement phase. And now you're going to go to the refinement. And again, I like to take a long, thin diamond to refine that lingual triangle, that cervical dentinal lingual triangle, because a lot of times, right there's a long diamond, a lot of times you don't have straight line access, and if you just remove a little bit of that lingual triangle right there, you'll be able to see the entire canal. We just reviewed the maxillary anterior anatomy, and now I want to switch gears and cover the mandibular incisor anatomy. So let's first talk about the mandibular central incisor. The average length in this tooth is around 21 millimeters, and the canal configuration is a type 1 configuration 70% of the time. And then you're going to see 2 canals in different configurations 30% of the time. So you really have to keep in mind when you are accessing and treating these mandibular incisors, you have to understand that there could be a second lingual canal, and often there is. Next is the mandibular lateral incisor. The average length is just the same as the central incisor. It's 21 millimeters. Now, thankfully, the majority of these cases have one frame and they don't have 2 separate foramina. Next is the mandibular canine. Like the maxillary canine, this tooth is a little bit longer. This averages between 25 and 26 millimeters. So you have to make sure that you have the correct long 31 millimeter hand files and rotary or reciprocation files. The great thing about the mandibular canine is it's a type 1 classification 93% of the time. So the majority of the time you're going to have one canal from top to bottom. Now let's discuss some of the fundamentals of access cavity preparation. Here is a diagram. It just shows kind of a general idea of where you want to start your access. Looking at the maxillary anteriors, I start a little bit lingual on these compared to where the blue dot is. And here's another representation for the mandibular incisors. You can see where the lingual access would start, and then you can see the 2 blue dots is just representing that there could be a second lingual canal, and to make sure that you have a small access prep, but large enough to be able to visualize to see if there is extra anatomy in that tooth. Now here's our access sequence. First, we want to penetrate the pulp chamber, so that's penetration. Then we want to enlarge or stretch it out, and then in our refinement stage, we're going to attempt to get straight line access. So we penetrate, we enlarge in the access, and then we refine it. Now when you access the pulp chamber, the number one thing you want to do is you want to be able to see. I use a microscope in all my access cases. Unfortunately, I know that's probably not realistic for all dentists to have microscopes. The next best thing is high magnification loupes with the surgical light attached. What you can see, you can do. If you can see the anatomy, you can treat the anatomy. So that's number one. Number two, you want to access with a rubber dam in place. I do almost all of my accesses with the rubber dam on, and I can see the anatomy, I can see the contours of the tooth, I can see the buccolingual mesial-distal orientation just fine with the rubber dam. There are some cases where you may want to access with the rubber dam off. I don't like to do that because I feel like the rubber dam keeps the lip and cheek and tongue away from the tooth and my drill, my burr, and so it kind of keeps me focused and isolated. But some of these more difficult cases, you may want to have the rubber dam off so you can see some of the contours of the adjacent teeth. Now, when you start your access, you're going to go slow. It's going to be small bites. You're going to continually stop. You're going to review your orientation. Okay, before you, as you're drilling into the tooth, you're going to make sure that you have the burr at the correct orientation. You want to check your mesial distal width, and you want to check your buccolingual orientation. What I like to do is I actually start with water on when I access. I start and I access about 2 millimeters into the pulp, or I'm sorry, into the tooth, and then I stop, my assistant will wash and dry the access so I have good visualization, and I will check again and to make sure that I'm at the right angulation. Again, the key here is small bites. Take your time, be patient, and make sure you're on the right path. Don't start drifting. All right? Now, when you have a chance, you're taking your time and you're comparing your access prep to the CEJ and the crown root orientation. You get a good sense for that. I actually take my burr and I place it into the access prep, and I make sure and I look at the facial dimension of the tooth, and I just want to make sure that I'm right on cue. Again, you want your assistant to continually rinse and dry after drilling and taking your small bites out of the tooth. Here's a great way to pinpoint your access. Divide your tooth in thirds, and then you want to penetrate that middle square. And you're not going to go straight in. You're actually going to start to drill a little bit lingual, facial and then lingual towards the pulp chamber. Here's a few access errors that can occur that you want to be careful of. Number one is drilling too facial. Usually that's a first or second year dental student that can do that. But you have to be careful of doing this and perfing out the facial aspect of the tooth. And the biggest thing where this will occur is if you're just going too fast and you just try to go for it all in one shot and you miss the pulp entirely and you go out facial. You don't want to do that. That's why small bites, take your small bites, go slow, and continue to reevaluate and look at your access prep. The second thing is we call it off-track drilling, or a mesial or distal drift, and there can even be a buccal or lingual drift. But really, a lot of times you'll see a mesial or distal drift as you go deeper and deeper into a calcified pulp chamber. Those are the cases that you felt you could get into, but you're realizing as you're starting to drill that it's a little bit more of a difficult case than you thought. So what you have to do in these cases is often you'll take off the rubber dam and you'll take a periapical radiograph just to check to see if you are drifting mesial or distal. Sometimes I'll take a CBCT to check if I can see where the canal is in orientation of my access. Okay? The third thing as I see is you can do too large of an access on the mandibular anterior teeth. So you really want to keep it small. You want to open up your access enough so you can catch all the anatomy, but you don't want to hog out the access, especially on those mandibular incisors. They have a pretty small mesial to distal width, so you have to be careful and you have to be patient and gentle when accessing those teeth. The last thing I see is improper case selection. I sort of touched on this earlier, but you really, really want to avoid those severely calcified canals. These are the cases where you don't be afraid to pick up the phone and call your neighborhood endodontist. That's what they're there for. Punt this, get it out of your office, have the patient go to the endodontist, let them deal with these difficult cases. An 84-year-old lady with a very calcified pulp chamber. Here's a couple cases I wanted to show from my office. This is a trauma case. This is a 20-year-old kid, and I did a consult on him. He came back 2 weeks later, and I have to be honest, I was not looking forward for him to him coming back. I did not want to treat this case because I knew it was calcified. The canal appeared mid-root, and this is extremely deep, and I knew this would be very difficult. I used a cone beam in this case to help me locate the canal mid-treatment. I highly recommend that you take this case and you know it's 4th and 20 and you're punting. You're getting this out of your office and referring to the endodontist. This was a very difficult case. I was very happy just to find the canal. Here's another trauma case of a young patient, a college student, and the same thing occurred on this canine. Very calcified canal. I was distal, you can see my distal drift. I could not find the canal. I was distally drifting. I took a cone beam and I was able to find the canal, 1 millimeter to the mesial, 1 millimeter to the lingual. The cone beam directed exactly where the canal was, and I was able to get a nice result. Here's a case that I think all of you can do. You can see this is tooth number 9. It's got a lesion, a periapical radiolucency. You can see that, but it's got a large open canal. And this is a fairly simple tooth to access and to get in the pulp chamber and clean out. Now, it's a necrotic case, so you have to take a little bit more effort and care into making sure that you've cleaned out the entire root system in this case, but this is a great case for you guys to treat. Here's another case. This is tooth number 9 again. This, I think all of you can treat this case. What makes this a little more difficult is there's a bridge on it. So you have to know how to access through a bridge, and you have to be confident that you can get into that pulp chamber. And I'm going to discuss accessing through a crown a little bit later. All right, let's discuss maxillary anesthetic. Here's a case, a video where the first thing you want to do is you want to apply topical anesthetic. This is a very sensitive area up here. So help yourself out, help your patients out. You want to be gentle, give them topical. The next thing I do is I do a infiltration with carbocaine. I use carbocaine because I just find it's probably the least painful injection out of all the anesthetics. You don't have to use carbocaine, but I just find that it just seems to be a little more gentle on the patient, especially when you're treating kids that have had trauma and they're already scared and they're sensitive. You try to be as nice as you can. I'll do a carpule of carbocaine to numb up the maxillary anteriors. I'll follow that with another carpule of 2% lidocaine, 1 in 100,000 epinephrine. Okay, I call it the 2 carp rule. I usually use 2 carpules up for the maxillary anteriors. What I'll do is I'll give a lidocaine infiltration, and I'll save about 1/8 of the lidocaine, and then I'll go to the palatal and I'll give a palatal infiltration. What I'll do with that is I'll take a small cotton pellet or a medium-sized cotton pellet, and I'll spray endo ice on the cotton pellet, saturate it, and then I'll place it right where I'm going to inject on the palatal tissue, and I'll kind of freeze the tissue a little bit, and then I'll remove the cotton pellet and I'll put the needle right in that white circle. What this does, this kind of numbs up the palatal tissue because this injection hurts. But I will do that, and I'll give about 1/8 of a carpule of the palatal injection of the lidocaine. Now what I'll do is sometimes that tissue is really tight, and you'll find that you cannot get the lidocaine into the tissue. So I'll actually put my finger on the needle to kind of hold it as I move it up, out, just a teeny bit. I'm not going out of the tissue, and I'm trying to find the right spot so that I can gently extrude the material, extrude the anesthetic. Now let's talk about mandibular anesthesia. There's a bunch of options you have. So I want to try to simplify this for you guys so you can think about the next time you treat a mandibular anterior case, how are you going to numb them up? If you have a tooth that's extremely symptomatic, in other words, it's a vital case, irreversible pulpitis / symptomatic is the pulpal diagnosis, I go with a mandibular block, and I will just numb them up. I'll numb the whole side of their face up, and I'll start with 2 carpules of a mandibular block, and then I will give a half carpule of septicaine on a buccal infiltration right next to the tooth. If the case is vital but the patient's not that symptomatic, there's other issues going on, you can get away with giving a mental block. And what I do is I don't use septicaine on a mental block. I will use lidocaine, and I'll go ahead and I'll inject near the mental foramen, and I'll remove the needle, and then I will take my finger and push the anesthetic into the mental foramen. It's the same technique that you guys all know from dental school. But that also works, and that'll numb up the anterior teeth. Now, if you have a necrotic case, and it's necrotic and it's really not that symptomatic in any sense, I sometimes can get away with giving a septicaine infiltration. You can numb up on the buccal or the facial infiltration. You can give a carpule of septicaine, and that will actually work. Sometimes that'll work enough for you to be able to file and treat that case. Now keep in mind, if you give a buccal infiltration, you won't have lingual numbness, so you have to be gentle when you place the clamp on in that case. Now let's talk about the rubber dam, placing the rubber dam. Luckily, the number 9 clamp is the best clamp to use for all the incisor teeth. For any maxillary teeth and any mandibular teeth, I use the number 9. This clamp works 100% of the time. Well, 99% of the time. It works, and it's very easy to put on. I place the clamp into the rubber dam, and I place it all together. Here is a slide where you can see where do you cut the maxillary incisor hole. And this is my punch. You punch it about 1 inch down from the top of the rubber dam, and that'll give you a perfect spot for when you place the rubber dam. It's still covering the lip, so you have the lip coverage but not the nose. Now, when you're cutting or punching the hole for the mandibular incisors, you have to go a lot lower. The biggest mistake I see for mandibular incisors or mandibular molars is people do not punch or cut the hole low enough. So you really have to cut it about 1.5 inches from the bottom of the rubber dam frame. And then this will allow you to place the rubber dam effectively and for the rubber dam to cover the upper lip. So the lip's covered, and that way it's not under the lip, so that when you're filing with your hand, you get saliva on your finger. That's one of my biggest pet peeves, was when my assistants cut the rubber dam hole too high, and as I'm working for an hour, I'm getting saliva on my finger because it's below the lip. Okay, so that's just a little tip there on the rubber dam placement and hole punch. Here is a video showing me placing the rubber dam on a patient, and my assistants already punched the hole. It's a maxillary tooth, 1 inch from the top. I have the number 9 clamp already in place in the rubber dam. I'm going to place the clamp and rubber dam all together, and it's very simple to put on. I will put it on, then I will take a glick instrument, and the back end of the glick, or the hockey stick side, I'll use that to remove the rubber dam off the wings of the number 9 clamp. One thing I do when I place the rubber dam, and you have to be careful, especially on the lower anterior teeth, you want to make sure that you're actually working on the right tooth. So if you place the rubber dam all together, sometimes you could clamp the wrong tooth. It can happen. So in order to prevent that, I put my finger on the tooth that I'm going to treat. So if it's tooth number 25, I take my finger, I put it on tooth 25, and then I place the clamp and the rubber dam right where my finger is, and I'll then move my finger and I'll place it over the tooth. Now after I do that, I'll even lift up the rubber dam and I'll count. 22, 23, 24, 25. Good, yep, I'm on 25. And then I check at my x-rays, my radiographs, and I make sure that 25 is the actual tooth that I am supposed to treat. Because especially the lower anteriors, they can be really tricky. They're all close together, they're small, and they all look alike. Okay, I would do this on the maxillary anteriors also. Do the same thing. Put your finger on number 9. And then when you put the clamp on and the rubber dam, you just want to make sure you're right, you're targeted the right tooth. It'll just prevent that little mistake. You definitely don't want to make that mistake. Now here's a rubber dam placement on a tooth number 10 that's rotated. Okay, this is severely rotated. In fact, it was so rotated that I was unable to go through a lingual access. I had to have a facial access on this. In this case, you can still place the number 9 clamp and the rubber dam the same way you would do all anterior teeth. It fits right on there. The only difference in this case is you have to, if you look at you can see that you can't access through the lingual. You have to do a facial access on this case. This is one of those cases that I feel that if you're confident and comfortable doing root canal treatment, you can do this case. But if you're a little bit unsure of yourself, this is a type of case that you want to refer to your local endodontist. I always say don't be afraid to call us and to use us, to utilize us. That's what we're here for. But there are plenty of cases that you guys can do on your own and get an excellent result. Now let's talk about our access burrs. What burrs are you going to use to access maxillary teeth and mandibular teeth? My 2 favorite burrs that I use are the 330 long carbide burr and the number 2 surgical round burr. Those are my 2 favorite burrs, and I use those burrs to access and penetrate the pulp chamber. After I'm penetrated the pulp chamber, I will switch over to a long, thin, tapered diamond burr, and that'll help me kind of to enlarge the access and then refine the access to get that straight line access. Here's your armamentarium. You have your access burrs, the 330 long, the number 2 round. I even use surgical length, the long burrs. I'll use a surgical length number 2 or a surgical length half round burr. And the reason I like surgical length is when you get deeper into a calcified access, you can't find the pulp chamber and you're getting deeper and deeper and deeper. What happens with the handpiece if you're using a short burr? The handpiece goes too close to the tooth and you can't see, you lose your visualization. So if you use a longer burr, a surgical length burr, and I'll use a surgical length half burr or half round burr or surgical length 2 round burr, it pulls a handpiece away from the tooth. That way you can see actually where you're drilling. And that's pretty important. You want to see where you're drilling. And I want to, again, restate this. When you're getting deeper on a tough access, go slow, small bites. Drill a little bit, and then wash and dry and make sure you have the right orientation. It's very important to take your time. It's okay to take 10 minutes to find a pulp chamber because that's where you're going to win the game. If you can't find it and you perf out and you're on the wrong side, the wrong area, then you've already lost your endo game. If you can find the pulp chamber, usually on an anterior case, usually you can finish it and have a good result. The next thing you want on your armamentarium, you have your Burs. Then you have your DG16, your Endo Explorer. This will help you locate those calcified pulp chambers or even a normal pulp chamber. If you can get the DG16 to stick into the orifice or into the pulp chamber, you know where you're at, you know you're there, and then you can start your enlargement of that area. You also have refinement Burs, and then we can talk about our orifice opening Burs. Here's an actual great endo access block. This has the number 2 surgical round burr. It has your transmetal burr to cut through metal. It's got the surgical length round burrs that I discussed, and it also has the long diamond for the refinement and the straight line access. Also, there's the X-gate for the open orifice or the coronal flare if you need that. So there's a lot of great burrs in this endo access kit. Now, once you're into the pulp chamber and you've done your enlargement, you've stretched out your access shape so you have plenty of access into it, and you've also refined it so you have straight line, I like to do my orifice opening. And what my favorite orifice opener is the Vortex 2508 orifice opener. You run it at 500 RPMs. It's got a nice sturdy 25 tip. And what I'll do is I'll place that into the orifice once I've gotten a loose 10 and loose 15 in there. And I'll just kind of open up that orifice so I get a nice open orifice. And I'll brush it to the outer wall, to the buccal or lingual wall. So here's kind of a illustration of the penetration phase. You want to penetrate into the pulp chamber. Okay, and you can use a number 2 round diamond or a 330 long carbide burr. And then once you feel the burr drop in, you've dropped into the pulp chamber and you've completed the penetration phase. Then we go to our enlargement phase. And the enlargement phase is again kind of stretching out that access and kind of opening it up a little bit, removing any of those undercuts, those walls. And once you've completed this phase, then you go to the refinement phase with your long diamond. And the long diamond, the refinement phase, just allows you to get more straight line access. Let's again just make sure we have this access technique down. You want to start your access prep with the water on. I do this to help prevent the dust from going in the patient's nose, and I'll make about a 2 to 3 millimeter access depth. Then I will stop, I'll turn the water off, my assistant will wash and dry the preparation. I will be able to look at it and to make sure that I have the right angulation. My 2 favorite burrs are the number 2 diamond round burr or the 330 long carbide burr. I think these are excellent burrs to help with your penetration into the pulp chamber. As I said, you start getting a little deeper. I'm turning the water off. I have my assistant have the suction close by to suction any dust off. And the reason I'm doing this is because I have better visualization. And this is really important when you get in those tough cases where you're having a hard time finding a calcified pulp chamber. So what you want to do then in those cases is turn the water off. If you're starting to go deep, you want to switch to a surgical length round burr. I will use a surgical length number 2. If that's too big in that prep, I will use a surgical length half round burr. And this allows me to have really pinpoint drilling, and I'll go very slow, very careful, and I'll take very small bites, and I'll be able to usually get into that pulp chamber even if it's calcified if I take my time. Again, use the surgical length round burrs in the deeper, more difficult access cases. Now I want to show you kind of a video as an example of our anterior access. Here's a case where I am accessing tooth number 10, and I'm starting with a number 2 round diamond. This is a great burr. You can see that I have the water on, so I'm initially starting my access with the water, like I stated before. And as I get a little deeper, you're going to see that I turn the water off, and I will continue with this burr, I'll continue to go to penetrate into the pulp chamber. In this case, it was a retreat, so it was not as difficult, but the same principles apply to your access. So I have the water, I'm turning the water off now, and then I'm going to have my assistant clean the access prep by washing and drying it out, and then I'm going to go back in and I'm going to access and penetrate the pulp chamber with the number 2 round diamond. Again, you could also use a 330 long carbide burr to do this. If this is a case where it was a difficult chamber, what burr would you want to switch to if you're getting deeper and deeper? You'd want to use a surgical length round burr to help visualize. You can better visualize where you're drilling. There's a lower anterior video, a lower anterior access video where I'm accessing tooth number 25. These cases can be very difficult to access. Not very difficult, but somewhat difficult because they have such a narrow mesial to distal width. So you have to be really careful when you access these teeth. I will start with a 330 long carbide burr or a number 2 diamond round burr. And I'll just go slow. I think the key here for this is small bites. You're taking your time. Take 5 minutes or so to get into this pulp chamber. I mean, 5 minutes is really an eternity of drilling into a small anterior access. But if you take your time, you can get in there and you can be successful in your root canal treatment. Now let's talk about how do you access anterior teeth that have a porcelain crown, either a porcelain fused to metal crown or an all porcelain crown. Let's talk about accessing through crowns. What I want to do is, if it's a PFM, I'll use a tapered diamond, and I'll obviously have the water on, and I'll do my lingual access. I'll remove porcelain and make a small access hole to the metal. After I've gone to the metal, then I will switch to my 330 long carbide burr. That's a great burr to punch through the metal, and I will do the same exact access prep as I do in all teeth. All I'm doing is just going through the metal. So I'm first removing the porcelain, then the second step is I switch to 330. I'll remove the metal part, and then I will access just like I did all the other, just like my other preps. Now, what about an all porcelain crown? Especially on the anteriors, we're starting to see a lot of those cases. Some of these and most of these cases are zirconian or Emax, some kind of very hard porcelain that you need a special, some cases you need a special zirc burr to get through this zirconian. These are the cases that you can use a tapered diamond. You have the water on the whole time, and I want to go ahead and make a small access on the lingual, the same spot we've been discussing before. Go ahead and get through the porcelain, whether it's regular porcelain or zirconian. Once you pop through the porcelain, I switch over to a 330 carbide long burr, or a 330 long carbide burr, or a number 2 diamond round burr. All right, here's kind of an interesting case. You have a tooth number 10 that's severely rotated. I'm blocked, my lingual access is blocked, so I'm unable to access this tooth lingually. So what do? I have to do a facial access. So I use my 330 long carbide burr, and I start with a facial, the same exact spot on the lingual, but just on the facial. I have to be a little more careful because it's a little different than what we're used to, but you're kind of doing the same thing. You're making an angulation down towards the pulp chamber. I recommend, again, take your small bites and take your time when you're doing this. I think this took me a couple minutes to access the pulp chamber, and because I wanted to make sure that my angulation was right, especially when you're doing a facial access. But this case turned out just fine. I was able to get into the pulp chamber. Just some of these cases, you're going to have a little bit of a curveball, and you got to think about what you want to do. And in this case, I did a facial access. So in review, I discussed the canal morphology of the maxillary anterior teeth and the mandibular anterior teeth. So you'll be familiar when you access those cases, you'll know what to expect. Number 2, I talked about profound anesthesia, and I discussed the 2-carp rule. I recommend giving 2 carps on maxillary and mandibular cases, and that usually will get the patient profoundly numb. Third, I talked about rubber dam placement, and my favorite rubber dam clamp is the number 9 clamp. And that will work 99% of the time on maxillary cases and mandibular anterior cases. Number 4, I talked about the different burrs to use. I talked about the number 2 round diamond burr to access. Also talked about the 330 long carbide burr to access for that initial penetration. Third, I talked about the long, thin diamond. All of these burrs are going to help you not only penetrate the pulp, but then to enlarge in the access and then refine the access. So I wanted to make it easy for you, and so 1 clamp, the number 9, 2 carps for anesthesia, and then 3 burrs for your access prep, okay? And then the last thing is to remember, small bites. Take small bites when you're accessing those teeth. Be patient. Have your assistant continually wash and dry the access prep and check your angulation to make sure you don't have any type of mesial distal drift, buccolingual drift, and you're right on the money. If you can do this, you're going to be successful in your root canal treatment. Thank you.